And so you may wonder, well, what is a toothless bulldog? A toothless bulldog is someone who has a passion or a vision or some need, and they will not let it go. And you could help them. And so they clamp down on your leg because they're toothless. It doesn't hurt, but they will not let go until you help them. And that's how Margie gets a lot of good work accomplished. She's even trying to help our field, forensic pathology, attract more people into it because that would help her field, injury epidemiology. So with that, I've known Margie for years. We're friends. We like each other, and I'm delighted that she's presenting to us today. Dr. Warner.
Well, thank you, Greg. I've never thought of myself as a toothless bulldog, but I I do tend to not really let go once I get my mind set to something, which is a good thing if there's not much necessarily support for something in the beginning. And what I do at the National Center for Health Statistics is look at trends in deaths. And oftentimes when things are inching up, there isn't a lot of necessarily support for things, but we can see big trends at the national level that an individual jurisdiction or state or whatever you want to call it, like a county or a state can't see because they don't have the the massive numbers of records on deaths that we have at the National Center for Health Statistics. And with the drug overdose deaths, which I'm actually going to talk a lot about today, because for a variety of reasons. First of all, I have COVID fatigue. I don't know about you guys, but tired of looking at the numbers of COVID deaths. So, and that is one of the things I do. But and I am, like Greg said, you know, involved in a lot of nameless publications at NCHS. But I decided to focus on the drug overdose deaths because it is a slow moving, well, it's a faster moving epidemic now than it was when Greg and I first started looking at it. And I can show you some of those data. But I am, the title of my talk, let me put up my slides. The title of my talk, and this is always the scary part to see whether it works. Can you all see my slides? Yep, I got the thumbs up. Great. So, well, that's not right. Let's see. I can see, you can see my slides, but I can't see. Let's see. Where did it go? Oh, okay, I can do it that way. Um, sorry, I'm fiddling around here. I'm
While
going
he's
to
getting
share
that
the.
going, Margie, I'm going to mention that I think Dr. Warner has no conflicts or
Oh,
disclosures that she needs to make.
yes, I was asked to say that. I absolutely have no conflicts. I am a federal government employee, which means that I have no conflicts. And in fact, anything I do, you can have access to. You can use, share, um, steal my slide, not steal, borrow my slides. I'm happy to have people use different portions of the things I say, the things I produce, and I definitely don't get any. In fact, UAB offered me an honorarium and I couldn't take it. So maybe someday, but not right now. So the title of my talk is Saving Lives by Studying the Dead. And that's really what I'm going to focus on today. How we use mortality data to help save lives by looking at trends in how the deaths occur and then trying and providing that information. I really am a statistician and I look at trends and I provide that information to people who really specialize in preventing deaths. And lots of times people think of public health as you know, prevention of deaths, but there's a whole component of epidemiology, which is really looking at trends and patterns and diseases in society. And that's really how it started out. And so my first slide is actually sort of a history lesson. I have a little bit of a history lesson here to talk about how mortality data has been used to save lives over time. So if we go back to 1665, this is called the Bills of Mortality, and these were put out in all over the world, really, but London is the one that people often look at because they were sort of the start of it. And you can see that in this week in London, this was a bill of mortality from London in 1665, and you can see that there were about 4,200, well, not about, they say there were 4,237 deaths due to the plague. And they also have a bunch of other things that people died of, fever, 348, and a couple of other things, women's, which or worms, 20. Anyway, you can look at these over time, but they were a way that people first started looking at mortality data, and it's sort of a precursor for, well, something bad's happening here. What are we going to do about it? And the saying goes, I have other ones of these bills of mortality where they have there are smaller numbers, but they used to tack them up in cities on they didn't have telephone poles, but on trees, so that people would know, should I go into this city or not go into this city? This is how many people died of the smallpox. Maybe I don't want to go there to have my mead or whatever it is they want. So fast forward to 2000 and what year are we in? 21. This is sort of a kind of bills of mortality for 2021, a really more advanced version of it, a lot fancier, but it does say the total number of cases and total number of deaths from COVID-19. So we're at 540,000 right now, which is an absolutely huge number. And I'm going to show you some other numbers so you can get a comparison to other causes of death. But it is essentially like a bills of mortality. We can look at these data by age, sex, race. You've heard all of this, where the person dies, which is of course really important to your field, and particularly to the medical examiners, because there was a lot of deaths that were happening at home at first. So just sort of a history lesson there. We have tons more data on COVID-19 on our website, and you can go here. I'm going to be talking a little bit about in this talk about how to fill out a lot about death certificate, because as Greg said, all these data come from death certificate. In fact, most mortality data you see comes in some way or form, has a touch on the death certificate, whether it's your death certificate is used as a screener, or if it's a national data. If it's local or county based, sometimes it comes from the medical examiner, sometimes it comes from different places, but national data is usually from death certificates. So we had reporting guidance and training on how to fill out death certificates, and I'm going to talk a little bit about that, our bigger program on that, as well as we have a lot of provisional data, which COVID-19 has really speeded up our our um, our ability to disseminate the data more timely. So go back to our little history lesson here. This is about motor vehicle traffic deaths, and I'm just using this as an example of how data are used with a great public health achievement of the 20th century, which is the decrease in motor vehicle traffic deaths. And you can see, you don't have to be a statistician to see that there's quite a dramatic decrease in the number of motor vehicle traffic deaths from, I start here in 1950. We actually have data back to when cars first started, because our data goes back to like 1870. Various national surveys were done. Uh, again, here's and I guess here's in 2019 leading causes of death, and I have shown this by age. So to give you a sense of the number of deaths from different causes, heart disease has 659,000 deaths in 2019. So COVID-19 is um, uh, quite close to that. depending on the week, you may have heard that that there are more COVID-19 deaths than heart attack deaths, but that, or heart disease deaths, but that may be by week because it does, mortality data, it does have a seasonality to it, which I haven't shown here. But I did want to give you a sense of the large number of deaths. Also in blue, green, and red, you can see the number of unintentional injuries, suicides, and homicides by age group. And as Greg said, I've been working in injury prevention for many years. I started out in safety, aviation safety, which some people say, well, what does that have to do with public health? And well, death is a very bad health outcome, as we say. So when you die from an injury, it definitely impacts your health. So we do use epidemiologic methods to investigate, to look at the patterns of those types of deaths in our society. So how do we prevent the deaths? And again, I'm giving an example from injury. I know that probably many of you have at least have some basic idea about epidemiology with the host agent and environment. For injury, we also use host agent and environment, and we also look at time, a time factor. There's other people that look at many other factors, but a most basic thing is to look at the um, event over what you could have done before the crash. For instance, I'm going to use traffic safety. What you could have done before the crash to prevent the death, what you could have done right during the crash, and then in the post-event phase. And then we think about the host being the person, the agent being the vehicle, and the environment, of course, is really important. So sometimes there's something called the 5 E's of safety. So you can think about engineering approaches to preventing any of these interaction between the time and the host agent or environment. You can think of education. At first, people said, don't speed. Now we have all kinds of ways to address speed, including I have traffic calming here in the second picture of a roadway. You may have seen something like this. They've actually found that putting, uh, medium, um, bar- I'm calling them barriers. The strips in the middle of the roadway actually helps slow down the traffic. And they've done studies, it doesn't necessarily cause more crashes, but definitely separating the bike from the cars is a way to prevent in the engineering phase. And that's in the pre-event phase. That's the best phase to prevent it. Airbags are great, but the person still may get very hurt. In fact, they may get very, very hurt and still end up in the medical examiner's office. So there's enforcement, and then there's enforcement. Cops getting out on the road. Emergency medical services made a huge impact, as well as an evaluation phase to make sure that things you're doing don't cause more harm and hopefully prevent the deaths. Um, but what it's wanted to sort of reinforce here, and what I talk a lot to when I work with medical examiners, and one of the reasons I like to work with medical examiners is because I think their hunches are really quite good. Um, and it's hunches that help me to then back up what their hunch with data, which it can be very actionable. So this is, again, an old example from 1970, but this woman, Susan Baker, who happened to be my uh, thesis advisor and who has a prize named after her name, National Association of Medical Examiners. She worked as an autopsy tech in the Office of the Chief Medical Examiner in Maryland, and she could see pretty quickly that infants seem to be more involved in crashes than adults. So she got data from the National Center for Health Statistics from death certificates to look and see whether her hunch was true. And in fact, it was true. And if you look on the left side of this slide, I show This is actually from her paper in 1970. What year was it? 1979. She used data to show that the for children 0 to 12, the death rate decreased by age. So that's that first slide on the first graph on the left. And then the next slide, a little over that, shows 0 to 12 months. And you can see that the infants are higher from the first slide. And then looking at it by age, that the very young infants had the highest death rate. So, this kind of actionable data really makes a difference. And she was able to get back those. She worked a lot on car seats, just going back to this slide, which in 1979 was just, people kind of heard about them. And I remembered the first child that I saw in a car seat. I'm that old. And I thought, oh my God, that poor baby. But, looking at that data, you know why it's important to use those car seats. If we look at, if we sort of think back to drug overdose deaths and some of the stuff Greg was saying, this slide shows the motor vehicle traffic death rate compared to the drug overdose death rate. And I go back to 1979, and you can see that the number, we already looked at that trend for motor vehicle traffic deaths, but during that time, the same time, drug overdose death rates were going up quite a lot, and they're still going up. And now the drug overdose death rate is almost the same as the motor vehicle traffic death rate in 1979. So I remember when the two lines crossed, and it made absolute headline news um, that the number of drug overdose deaths surpassed the number of motor vehicle traffic deaths. And now people are kind of used to it. So I'm going to show you some of those trends, but just bear this in mind that it is going up. And Greg mentioned I started working with him around 2000, in 2003 and 2005. That's sort of when we were really getting worried at the National Center for Health Statistics. But if you look back in 1990 to about 2000, you can see that it was already starting to go up. So we had an inkling of what was going to happen. So that's why we started working more closely with medical examiner and coroners to get better data. A lot of people didn't believe this was the case. They thought there was something about the data. And the medical examiners were saying, no, I know there's more deaths in my morgue. So fast forward again, or not fast forward, this slide starts in 1999 and goes to 2019, and it shows the types of opioids involved in deaths. And you can see that synthetic opioids other than methadone has really risen in the number of um, deaths involving these types of drugs. So that involves fentanyl for the most part, and the analogs, as well as a much smaller number of deaths involving tramadol. But it went up um, 75% per year, an average of from 2013 to 2017, and then it's a 9% per year from 2017 to 2019. So it's going up quite fast. It's a little lower of a increase, but it's still going up quite dramatically. Um, if we look at drug overdose deaths by the type of stimulants, uh, they are also increasing. This is on the same scale, so you can see it's a much lower rate of deaths, but it's still increasing. And yes, some of these stimulant deaths and the opioid deaths happen simultaneously. So the person dies from a combination of stimulant and opioids. Um, and we are working with medical examiner and coroners to get a better handle on this, to try to learn more about the multi-drug toxicity deaths. And that's some of the stuff we're working on with with the different coroner or medical examiner around the country. And I know Dr. Brandy McCluskey's on the phone, and she's working on looking at, we had a project with their office to look at ways of surfacing the data in more sophisticated ways, data visualizations that can help them both check the data that they have and create and better understand and show the data that they have in their office. So I'm going to talk a little bit about death certificates and the vital statistics mortality data, because this is a grand round, so you're supposed to learn something other than a few fun facts about history of injury prevention. Um, so the information from the National Vital Statistics System, all the data I just showed you, is based on data from death certificates. They're filed in all 50 states and the territories for every single death in the U.S. The data are shared through a cooperative agreement, and it's the federal government. We provide funding, coordination, standards, and cause of death coding, and the states maintain their autonomy and operations. So Greg described me as a toothless bulldog, and that's because I actually don't have many teeth. I can't really do that much. There's a lot of autonomy within the states, but I try to ask nicely, and we really try to work with our state partners to improve the quality of the data. And that takes a lot of coordination because states do things differently, as we all know. So the data include demographic, geographic, and causes of deaths. So we can look at a lot of different factors for the deaths using the death certificate data. So the demographic information is collected or filled in by, this is a death certificate, the U.S. standard death certificate. Actually, most states are electronic now, but this is a good way to see it. The demographic information is completed by a funeral director, and the medical information is completed by the attending physician, nurse practitioner, physician's assistant, depending on the state. And then for sudden and unexplained deaths, it's completed by a medical examiner, coroner, or justice of peace. And we can talk about that later, but I'm assuming most of you know a little bit about the medical legal death investigation system in the United States. This is the cause of death section of the death certificate. In case you haven't seen one, I'm assuming you have, but just so you know, we have a cause of death section. Um, the main thrust of the cause of death section includes part one, which is the causal sequences leading to death. So each cause should be due to another cause, and it should be sequential. With on the lowest used line is the underlying cause of death, which is a disease or injury that initiated the events leading to the death. We want other significant conditions in part two, so things that aren't in the causal chain but may have contributed to the death would go in part two. A manner of death is, of course, very important. And then we have a how the injury occurred section. There's a lot of other things there that need to be filled out, but that's how we get the causes of death, which are what we're talking about today. The deaths are coded using the 10th revision of the International Classification of Diseases. Some people ask why we use ICD, and you know, um, questions about the ICD, but for mortality data, all WHO member states use the ICD, and it's developed by an international work group. So the U.S. Is part of that work group, but we are not in charge of the International Classification of Diseases. And one of the reasons it's translated into 43 languages, just so you know. The reason I say all this is because we'd use these data more and more to compare to other countries. And that's getting to be quite, in my career, getting to be quite a bit more common and more robust, those comparisons. So that goes on behind the scenes. The underlying cause of death, again, I just repeat this is the disease or injury that initiated the train of morbid events leading directly to death. And it depends on the underlying cause. People ask a lot of questions, but it does depend on where and how the conditions are reported on the death certificate. But if I leave you with one message about cause of death coding or filling out the death certificate, and uh, any of the doctors in Greg's office can share with you in great detail about how to fill out the death certificate. The one important thing is on the lowest used line of part one, be sure to put the underlying cause of death.
Dr. Warner?
Yeah.
Yes, I have a question on that. On the statistics you were showing early, you highlighted the overdose, drug use, and then the accidents. Presumably, a lot of these drug users are more likely to get into and die in car accidents. If they're under the influence while they die from a car accident, do you split the difference in the statistics, or do they have to physically die from the drugs in order for it to be a like a drug related death?
Well, that's a really good question. So uh, it really depends on how the death certificate is filled out, first of all, because and the types of anal uh, uh, um, work that the medical examiner and coroner would do to determine the cause and manner of death. But for the most part, for traffic accidents, they would most medical examiners, I believe, would if they believe that the person ran off the road because um, they would call that trauma, the underlying cause, the motor vehicle traffic death. And maybe, oh, Greg's given me the big thumbs up. Many will not actually write the drug on the death certificate, and that is sort of something that's been discussed a lot. So if the person was under the influence, even heavily under the influence, that some medical examiner and coroners would not write the drug on the death certificate. With that said, we do get a number of death certificates with motor vehicle traffic and drug, but the person it wouldn't be a drug overdose necessarily. It would be the influence of the drug. But one of the things we're doing, so thank you for, I'll give my, um, as I mentioned, we're doing a lot of work at the National Center for Health Statistics to try to um, surface the information that the medical examiner and coroners have in their offices. And Department of Transportation is quite interested in driving under the influence as a sort of follow-on to driving under while intoxicated. So they are quite interested in getting this information from medical examiner and coroners, but it's not necessarily part of the death certificate. And actually, thank you for asking a question. If anybody else has a question, feel free to hop in. I know this is when it's during in person, it's much easier to see if people look confused or falling asleep, or I don't know. uh, I can read the audience better, but please do jump in if you have any questions. Um, So we code the causes of death, and actually using what we call the literal text, or what's written on the death certificate. So if we have more than one cause written, we do code all the causes. So we would know if a drug was written on the death certificate, um, and would be able to review those. So as I mentioned, we try to promote consistency and uniformity in death certification. We got some pullback from people saying, oh, during COVID-19 that there's not any rules for filling out the death certificates, and there's no books about it, and there's anyway, there are plenty of books and plenty of reference guides and different ways that people are told how to fill out the death certificate. I have some here. Dr. Davis has helped tremendously in some of these reports, as have others within his office. So sort of focusing on the death certification a bit more. This is a position paper that Greg worked on. He spent a huge amount of time on the recommendations for investigation, diagnosis, and certification of opioids and other drugs. This is a second position paper that the National Association of Medical Examiner puts out, and it really talks about the science of the investigation, as well as, how do you decide if it's a uh, trauma that involves drugs? Do you put that on the certificate? How do you report that? How do you figure out different parts of that? But I'm not going to dwell on that. That's not my area. But we did, CDC did work with NAME to try to get the pathologists, the forensic pathologists and toxicologists to come to agreement on this certification and how the procedures to investigate these deaths. We did write a certification guidance to make sure that the certification was done uh, as uniformly as possible, because there was a lot of problems with people writing things like drug overdose or drug toxicity and then not including the drugs, and we really need those drugs. We really, to do our epidemiologic research and show slides like I showed, we really appreciate when the medical certifiers include the name of the drug that was involved on the death certificate. And that's turned into a course, an online course, and Dr. Dye did a lot of training in Indiana based on the reference guide. So, just talking all about UAB, but a Jefferson County Medical Examiner's Office. But that's some of the work that we've done together. So we're trying to make the data more actionable. And so, mortality data used to not, especially vital statistics mortality data, it was like the plumbing of public health. Uh, if you don't pay attention, you expect it to work, you expect to open the, turn on the spigot and out pours data, but that's not the way it works. You need to make sure that plumbing is and all the infrastructure is there to keep that data flowing. And back in 2010, we started really focusing on getting the data in more quickly. And a lot of this had to do with the drug overdose deaths not being very timely, but we overhauled a lot of the system. So in 2010, only about 7% of the records came within 10 days of the date of death. But by 2020, it's about 67%, which is a huge increase. And it makes us able to do amazing things with the COVID-19 reporting, which I shared with you earlier. So that 80% target of records received within 10 days is not um, without logic. About 20% of the records are injuries, and those do tend to take longer to investigate and certify. So that 10 days may not be even possible, even under the best circumstances, to get those data in quickly. So, in the point of fact, drug overdoses are the ones that take the longest of any cause, with the exception of maybe infant deaths. But we are making great improvements in how quickly those data are available to us. We also, with some of these certification guidelines, have gotten medical examiner and coroners to include the drugs listed on the death certificate. And we're now up to 94% of death certificates, drug overdose death certificates, have a drug written on the death certificate, which is just a huge improvement from 75% of death certificates having the drug included on the death certificate in that's about 2012. And the good news is that that is really uh, being able to show such a big improvement has really enabled us to do more. So having the support and the medical examiner coroner work with us to improve the specificity has been a tremendous uh, advantage for preventing the deaths. So we have more timely provisional data. So I'll go back to showing you a little bit of the provisional data on drug overdose deaths. Um, uh, and by provisional data, I mean every year we put out a final data file that actually we send the information to Congress about how many deaths there were in the United States. It's what's used for the official statistics. And but now we're able to put out more timely statistics, which helps people understand what's happening in the here and now. So this is a good example of why it's important to have these provisional data. With the drug overdose deaths, I think there was a lot of between 2017 and 2018, the number of drug overdose actually went down a little bit, and there was a lot of excitement about that. It was the first time in 20 years, or probably more than 20 years. But unfortunately, that did not last. And this data show the 12-month period, so a year period starting in August of 2020. Um, and during that 12-month period compared to the previous 12-month period, the number of deaths went up the rate went up 26%, so 27%. So that's quite a large rate. It's the predicted number of deaths for that period is 88,000. So just quite a large and staggering number of deaths. So we've also moved into something called nowcasting, which maybe you haven't heard of, but this is a new thing. You may have heard of forecasting. That's when you get to figure out what's going to happen in the future. Well, with drug overdose deaths, we can't even figure out, right now, that previous slide, we have a 6-month, what's called the 6-month lag. So we use data from today to predict what happened 6 months ago. With nowcasting, we're able to get it much closer to the now. It's not quite now, but we use more sophisticated. That other model was very unsophisticated weighting. This is quite a sophisticated model. We have ways to predict the number of deaths. And I'm going to tell you the actual fact, which is the number of drug overdose deaths during the time of the pandemic. So that's starting at week 5. These are called MMWR weeks. So it's the weeks of the year. And week 5 is when the pandemic started, according to, I don't remember how they picked week 5. I think that, anyway, the blue line represents the average over the period 2016 to 2019, and the little dots are the actual point estimates for each year. And then the green line is what happened for 2020. And you can see that there was quite a large peak in 2020, around 2,000 deaths in 1 week, and about week 19 of the year. So, unfortunately, what people thought might happen during the pandemic happened, which is that there were quite a large number of drug overdoses. And the medical examiner, again, their hunch is that from what they've seen in their office, that this was happening, and it is in fact happening. So again, I wanted to say that NCHS and CDC, we're trying to do outreach to medical examiner and coroners to promote the quality and consistency in death investigations, enhancing the efficiency of data collection so we can do more with all the information that's sort of stuck there in their office, and also so people stop bugging them to get more information from them, and also so they have better use out of their own data. To look at trends within their county, and also quality control, how many people are doing this test or that test, or should I do this test or that test, different ways of using their own data. We're trying to
Margie,
yes,
may I ask you a question?
sure,
Could you go back to that nowcasting slide? That's fascinating.
yeah,
This is new to me. So I just counted up. Week 19 is about mid-May.
that
And
sounds
so
right.
I was wondering if that corresponded with when the first stimulus package went out. But I think that that stimulus package was more in late June, early July. Am I remembering that correctly?
Um, I don't know when the stimulus package came out. Unfortunately, I did not get any stimulus, but not that shouldn't. I have not looked at what the reason for that peak, Greg, and that's there have been people that have talked about that as a possibility. Some of this has to do with the new um, synthetic drugs that are out and multi-drug toxicity. And I didn't look before this talk if it was in any particular region of the country, but
Oh,
that would be a good way to sort of see whether it had to do across the board. But
well,
I don't.
it's surely multifactorial. And Brandy actually on the chat just made the good point that supply chains had to have been interrupted some way, somehow. But I just, I had the thought, I mean, we all, forensic pathologists across the nation, experienced that peak because it was an increase in our work. But I had, in my own mind, I had associated it with the stimulus package, but I think your data are showing that in fact it preceded the stimulus package a little bit. In any event, these are the sorts of things that Margie's type and that my type sit around and think about when we have time to think.
Actually, I just found an
Thank you.
article that said the first ones came out mid-April. So this is
Oh, it is the
tracking.
effect of that, or it can be the effect of that, because that was our percent. I mean, here
That was our hunch at the time. I remember walking into your office and saying it. Yeah. I
here are
think
people who had a job. Now they're forced to stay at home. They're given money, and for those who use drugs, I mean, there's nothing else to do. I'm not throwing stones at them. I'm just saying here's a circumstance where you've created the conditions that you would expect to lead to that kind of peak. So, anyways, that was an interruption, but thank you.
Yeah, well, like you said, Greg, I think it is multifactorial, and I will go back and look at what the date is, and remember that these are predicted. So the green line is the predicted, and there's some.
All right, I thought the green line was the actual, but
Well, the green line is the yes. Well, the green dots. Let's see. Uh, the whole thing is predicted, so it's
okay.
based on a two-phased analysis where we first looked at the percent of records that were coming in at that time, trying to estimate how many, because there was changes in how quickly the records were coming in. And then we also did a second phase based on the actual number, because the numbers are bouncing around a little bit. But I didn't prepare too much about that because but I think going back to the multifactorial idea is really critical, because there was a lot of stuff going on with people's disruption to their treatments, people's in addition to the disruptions in their job and all kinds of things, there was also disruption to treatment and that kind of thing as well.
Thank you.
So, so I thought I'd stop, or I have my last slide. So we're trying to coordinate public health surveillance efforts in offices of medical examiner and coroners. And one of those things that we've been told over and over again is that there's a shortage of forensic pathologists, and we really are starting to think about this at the national level, and you know what it's going to take to increase the supply of forensic pathologists, because we know we can't get good data without good investigation. And so I put up a slide here just showing where forensic pathologists are around the country, and you can see there's a dearth of forensic pathologists in the middle of the country, and there's a shortage in general. The National Association of Medical Examiners just put up a YouTube video on how to become a forensic pathologist. So if any of the students out there are thinking about it, they can watch this video or just go bug Greg. But in sort of talking around the country, we've gone to several different states. I don't think we've been to, I've talked to the state of Alabama about some of the issues with medical legal death investigation within the state of Alabama, but not about the supply of forensic pathologists. But we've also gone to different states talking about forensic pathologists, just alerting the state health officer that a shortage of forensic pathologists may result in problems with the data, shall we say. But then what we've been told, or what I was learned after we did that, was that there's a shortage of all pathologists. So I assume you guys all know this, but it's pretty amazing, and there's going to be a shortage of doctors. I think there already is a shortage of doctors, and who knows what's going to happen after this pandemic with people's choice about what they want to do in the coming years. But there's a shortage of pathologists as well. So we are looking at this at the national level. So I wanted to put a plug out for all the data out there that you guys know, and all the hunches you have, and sort of think about how you can use the data you have to back up your hunches, so that you can let well, some of you are researchers, so you're going to be preventing deaths that way. But how the data or how the work you're doing can inform the epidemiologists as well as your own research. So I have some references here, and I'll well, I don't know whether you get the slides, or if you want the slides, you can email me. My email is here, and I'm happy to answer questions.
Thank you, Margie. That was excellent. I'll give others a chance first. I know I have a question. Alan, you want to get on and ask your question?
Sure, I can do it by voice. How much do work goes into connecting the vital statistics data that you have in your database with correlating it with other agencies' data? I'm thinking most prominently of VA, because I'm at the VA, but also National Transportation Safety Board, FBI, looking to extend causes of death beyond the death certificate.
So that's a great question, and the answer is really multifaceted. So first of all, we do compare data all the time. So sometimes data systems are totally independent of each other. There's a few of those with deaths, especially when it's a smaller number of deaths, or it's a shorter time range. Like NTSB will collect their own information on the number of deaths, and that's one of their missions. They may actually use death certificates to confirm deaths and confirm the causes of death, and I imagine they do. I haven't actually talked a lot to people at the NTSB, but never asked them that question in particular. But so one of the things that I do a lot is answer questions from other agencies, like, well, why do you think your number is different than my number? And we do spend a lot of time on that. I compared, another example is the homicide statistics that come from the uniform crime reports, and those are independent of death certificates, and the number is different. So we do spend a lot of time sort of comparing back and forth, and there's been a number of different studies of that.
Okay, and I mean that's good. Yes,
Yep.
Brandy has identified my my obsession, which is de-siloing data. But I was actually going more for if for instance, VA is very interested in why veterans die, but they're also interested in, because they have a defined population, how their interventions
Right.
impact death in particular areas. So
Right. I should have started with the big overall. There's independent data where we compare. There's data where we link our data with other data sets. And that's an example we do with VA. We have a pretty large record linkage project that we work on with the VA, uh, uh, the epidemiologic group at the VA in Washington. I don't know enough about the VA to know what that group is called, but we do link actually data together for that study. And I'm happy to share with you the names of the epidemiologists who work on that
that would be
project.
excellent.
Yeah, so it started, I'd say about 10 years ago, I think, with the suicides. They wanted to know how many suicides there were amongst their population. And so we started linking the data together. And we do other linkages with people I'm not sure whether you're familiar with the National Death Index. But the National Death Index is a way for researchers to find out if people in their study population has died for one reason or another. And some of that reason is just to make, censor them for, say, what's that called? An analysis over time. Forgetting the name of that kind of study, but time series analysis or anyway, they want to censor the people to not include them in the study. They also don't want to be trying to contact somebody that's no longer with the study. Sometimes they do want to know the types of way they died, but we have a national death index, which is based on the death certificates. A different system, but it is based on death certificates. And then we have I'd say there's a third way that the death certificates are used, and that mostly happens within the state. So states will use the death certificate kind of as a screener to find out about a particular cause of death, say drug overdoses. Well, let's start with suicides and homicides. There's been a 20-year program to review death certificates looking for homicides and suicides, and then following back and collecting more information about those decedents from law enforcement and from the coroner and medical examiner. And that's called the National Violent Death Reporting System. National Highway Transportation Safety Administration does the same thing for their fatal accident reporting system. In other words, they find out who's died either from the police or from a death certificate and follow back. And then there's also, what was the other one you mentioned? Oh, the infant deaths. They often states will look at infant deaths using the death certificate sort of as a start. And then there's also sometimes follow back surveys where they'll find out people who died from death certificates and then try to find out a little bit more about them. And we merge data from death certificates. We have a very large linkage program. So from certain surveys, we'll link death certificate data, or it's actually the NDI, to survey data to try to get more information out of the collected data that the US government has already collected information from decedents. But the person, when they're alive, has to agree to that further linkage later on. So, yeah.
I was going to say, Alan isn't the only one that would like to know whom we could contact in the VA. Those epidemiologists you referred to are the people. We Friends of Pathologists would love to talk with them.
Yeah, and Greg, that's something we've talked about in the past, and maybe this is a great forum for
Yes.
or reason to contact them again to try to sort of
Improved death certification.
improve death certification, which is our concern. And I'm surprised at how I think the information about the merge data that the VA does, I mean, there's a lot of confidentiality issues associated with those data. So I think that's why it's not like widely known. If you read the reports, you can see that it's linked, but I'm happy to share the names.
Yeah,
Aaron
please.
Schneiderman was maybe a couple of years ago was the lead on that, but I can share you the name.
Yeah,
of-
please send them to me and I can easily send them on to Alan and get you Alan's email.
Okay.
Are there, I have a question if there's time, but I want to give others a chance to ask you first if there are other questions from everyone.
So I
Oh.
did actually have a follow-up question, and you alluded to it a little bit with the homicides. There was a story earlier this week on NPR about the mass shooting that went on, and about how there actually wasn't a decrease in mass shootings in 2020, like a lot of people have thought. And what they were implying, and this gets to some of the granularity of your data, when you're doing the composite data, how difficult is it to get into the regional things? Like they highlighted specifically in Chicago, there were actually 36 mass shootings last year alone. But until you get to the actual regional data, it was really hard to tell that.
Yeah, so that's a really it's a really good point. I hadn't heard the story, so I used to listen to NPR on my way back and forth to work, but I don't do that anymore. So. But let me tell you a little secret. It's not a secret, but it's a thing that we're working on, which is that we do not have a good way to know if the deaths happen at the same time. So we can know the time and place of the death, but that may not be deaths that happen at the same time. So if somebody dies, there's a multiple homicide, the person may not have died at the same time. So
you need actually to help the NCHS, we actually would explicitly say on death certificate, 1 of 4 people shot and killed. But unless you write something like that on the death certificate, they really have no way of knowing. I mean, it could just happen to be 4 deaths that occurred at this intersection because it was a bad part of town, period.
Exactly. And some states have ways to link them together at the state level, but we don't have that at the national level. So those statistics come from people who compile it from news reports, as you know, CNN is an example. And there are other people that compile that information that way. So I can't really speak to the mass suicides, although now that I'm thinking about it, the National Violent Death Reporting System that I mentioned, where they look at death certificates and law enforcement records and what was the other thing? Oh, coroner medical examiners records. They do have information on that. So I can't speak to that, but it is something that a lot of people have been doing more on their own, and that's happening more and more with causes of death where people are. The old saying was that you couldn't do newspaper clippings to study mortality, but it is getting more efficient to do that with Google. And in fact, during storms and during times of in that crisis point time, many medical examiner and coroners are now putting up information as they know it about the deaths in their area. And I'm not sure whether you know, different states and offices have protocols that they and ways that they can and can't do things. But I just heard that some counties tweet the number of homicides. So Greg's raising his hand.
Oh, well, I was going to say the hour's up. So I know some
Okay.
people surely need to go, and you may need to go too, Margie. So I first want to thank you for for presenting to us. It's a wonderful presentation, and I hope that it sparked ideas in people, but it was an excellent presentation of what you do and why it matters. Also, if you've got just a moment, if you want to stay on, if anybody wants to hear, I'll ask my question while you're still here.
Well, I just feel bad. I didn't see all these questions in the chat because of the way my thing was set up. So
I think actually we addressed all of that that's in the chat. Some of it was crosstalk back and forth based on things that you said. There weren't questions so much as some crosstalk. This is my question, and before I say it, I'm going to promise you it's not going to be as political as it's going to sound like when I start. All right, because that's something you didn't address at all, but that we've all learned, I think, is that politics have now gotten completely sewn up into all of this too. Because if something suddenly becomes of great public interest, it becomes a political interest. So here in Alabama, there's a bill in our state legislature to change the authority that public health departments in the state have over people's actions. So in other words, that you could no longer restrict movement as was done early in the pandemic without having basically, as I understand it, a board of business individuals review whether this is actually good for the state or not. And so this board of business practitioners will have the final say-so over public health practice in the state. I'm not asking you about that. What I want to know is, in your look at the history, has that sort of thing come up in the past, like after the 1918 influenza or those sorts of things, where people said, oh, well, we put these public health institutions we created them, but we didn't actually ever mean them to do anything. We just wanted it to look good. So has this happened before?
I don't know whether you know what's amazed me, I'll just tell you my 2 cents is these are quite large number of deaths for COVID-19, and there's been a lot of discussion about how correct the numbers are for the number of COVID-19 deaths. And we got criticized a lot about, putting out guidance that basically said to certify the deaths the way we say to certify every single cause of death. And we've done a lot of excess death studies, and I haven't shown those here, but those are showing that there's probably more deaths than there potentially more. I think that there's been a lot of politics in sort of how this is rolled out, and I don't know. That's just.
Well, I think you and I have been used in the past to working in anonymity, but I'm not sure we're going to have that luxury anymore.
I don't think so. I can't believe how many people are talking about death certification and the consequences of it. And I think it's a good thing overall to have more data and more accurate data. So overall, I think it sheds some light on some of the shortfalls of the system, as well as pushing us to do more and better and faster. So
yes, I agree. Well, thank you so much, Margie, for presenting to us, and we really appreciate it. You can bet we will stay in touch, and we want those names of those VA epidemiologists.
Yeah, I'll get that to you right away.
All right, thank you.
All right.
All right.
Goodbye.
Bye.
Thanks for having me.
Yeah, we'll have you back to Birmingham sometime. You've been before. There's some new restaurants for you to try. So
I know, that's
come
why I
on
want to come back.
All
Thank
right.
you.
Take care. Bye.
Bye.
Bye, Margie.